Class, welcome to MedSurg 2 Unit 1, where we start off by talking about adult health and nutritional assessments, and then we dive into first of our 2 units discussing gastrointestinal problems, treatments, diagnostics, all that good stuff. One thing I want to introduce to you guys early in the term is assessment priorities. So in MedSurg 1, you've learned a lot about quality assessments, how to do some focal assessments. In Fundies, you learned a head-to-toe assessment. This term, we're going to turn things a little bit and start talking about prioritization. So basically, when you step into a patient's room, you should be thinking ABCs, airway, breathing, circulation. Do they have an open airway? Are they breathing adequately? And is the blood circulating or perfusing? Then we're going to get our vital signs, then we're going to do our pain assessment, and then we're going to focus on whatever body system is impaired. If you are on a post-operative unit and you have a patient that has a post-surgical site and COPD, you would do your airway, breathing, circulation, get a fresh set of vital signs, do a pain assessment, and then you would do 2 focal assessments. You would assess the surgical site and distal to that, and you would do a respiratory assessment because we know that the patient has those 2 problems. Then if those were within normal limits or as expected per their progress, we would transition to a head-to-toe assessment. If there's any problems with a specific body system, we would go more in depth into that body system assessment, decide if we need to branch out to anything else. For example, maybe we need to listen to the heart and check the pulses. Notify the prescriber of any red alert symptoms or problems that you've assessed. And then we would go back to the patient room and do our head-to-toe assessment after taking that step. So that's a common scenario that nurses have to deal with on a daily basis, and we're going to start talking about that this term. The other thing we're going to talk about is prioritization in terms of nursing diagnosis, and this is going to occur chiefly on the discussion board. So the discussion board is incredibly important this term, and I'm going to have some specific expectations that I'll discuss with you our first week in class. But this is an example of ranking nursing diagnoses. So just because a nursing diagnosis is applicable to a patient's situation, it doesn't mean it's a top priority. So for example, on this screen, we've got anxiety, ineffective coping, ineffective airway clearance. Only one of those is a high priority, and that's the physiological. The highest priority is always going to be the physiological nursing diagnosis, and that's per Maslow's hierarchy, which should be something you're very familiar with at this point in time. So when I ask for nursing diagnoses, whether in class or on the discussion board, I only care about the high priorities because those are what need to be done first, and those are what can save a patient's life. So we'll be talking about that a lot on the discussion board, and this is just a specific example of that. So this leads to a little bit of frustration. So sometimes on the discussion board, I'm going to say, while you have a nursing diagnosis that's applicable, it's not a priority in this situation. It can be a little frustrating, but this is to help you hone in on what you need to do first as a nurse, and that's going to help you in the real world, and it's going to help you when you go to sit for your boards as well. Okay, so let's talk a little bit more about the components of a physical exam. As soon as we step into the room, we're going to make some general observations about our patient, and this is usually where we start off with our nursing note. How did you find your patient? What was their posture? What was their body movements? What's their speech pattern? Did they seem to be in any distress? And then we're going to focus in on what's going on with my client. What are their signs and symptoms that I know about it? What are their medical diagnosis? what are their potential complications, any upcoming procedures, post-procedural, etc., etc. And then we're going to do our vital signs and our pain, and you've got to get a full set of vital signs and a quality pain assessment. And then we're going to focus in by body system. Body system. For example, if the patient has a foot wound infection in a central line that we're giving antibiotics through, we need to do focus assessments on both of those issues immediately. And then expand if there are any abnormals with those two things. So that's just an example. Another example is maybe they're here for gastrointestinal reasons. So we need to do a focused GI assessment. So that would be, are you having nausea, vomiting? Are you eating and drinking? When was your last meal or last drink? When was your last bowel movement? What did it look like? Do you have any constipation, any diarrhea? We're going to visualize, inspect the abdomen. Then we're going to auscultate all 4 quadrants, and then some light palpation. And that is a focused GI assessment. And so each body system has its own focal assessments, and that's what we're talking about. So depending on what the problem is, and patients can have 2 to 3 and onward problems, you need to do a focus assessment as your higher priority, and then move on to a full assessment. So one thing we're going to talk about first specifically is a nutritional assessment. So what's it going to provide us? It's going to give us some information about, do they have too much nutrition, borderline, or are they just straight up malnutrition? We have a problem with nutritional deficits in this country. We have a problem with obesity in this country. And we need to know, who should we assess for a nutritional assessment? Well, we should do a nutritional assessment for anyone that's of an advanced age, anyone that's experienced weight changes, whether expected or unexpected, any client that is having difficulty affording their healthcare needs, for example, new glasses. We're going to assess anybody that's had a significant life change or stressor. So that could be things like being a widower, being divorced, retirement, a recent surgery, particularly gastrointestinal in nature, and of course, growing children would be a great one. And as a part of this nutritional assessment, we need to make sure that they're not having any difficulty swallowing. That would be a priority assessment. Some other things that we're going to look at is body mass index, your BMI, and we're going to talk about that a little bit more on a future slide. We're going to assess waist circumference, and that assesses for excess abdominal fat. And for guys, it's greater than a 40-inch waist. For girls, it's greater than a 35-inch waist. So the reason why we look at the waist circumference is because having a high waist circumference puts patients at risk for diabetes, lipid disorders, hypertension, heart attack, stroke. We're also going to look at our clinical examination findings, and we're going to look at dietary data. There are some labs that we're going to frequently see, and those are things like albumin, pre-albumin, electrolytes, hemoglobin, hematocrit, urinalysis, and cholesterol levels. And we're going to talk about these labs that you need to know a little bit further in on this PowerPoint. And just know that if a patient has an abnormal lab level, we need to continue to check back to see how they're progressing in their treatment, whether if it's a low lab, it's getting higher. If it's a high lab, is it getting lower? Are we meeting our treatment goals? There are other influencers that can affect nutritional status, cultural beliefs, socioeconomic status. Meat can be particularly expensive. Maybe they're not getting an adequate meat intake and therefore are going to be low protein stores. A common intervention for that is to recommend that they increase their egg intake because eggs are an inexpensive and great protein resource. Some people are vegetarians now, but vegetarian diet can be rich in carbohydrates, but are they actually getting enough of dark green leafy vegetables, beans, those sort of things that are good sources of iron? You need to keep all these things in mind when you're talking about nutrition. Um, and then specifically with adolescents, we need to assess their nutrition because they're at a critical growth state and obesity is a rising concern. And then, particularly with females of childbearing ages, we need to look at their iron levels, their folate levels, and all females, their calcium levels. So, a lot of information, a few key points that are going to be part of our nutritional assessment is their BMI, our clinical examination findings, dietary data, and then those lab values. So that brings us to lab values to know. So, nutritionally speaking, some common labs that we look at are albumin, which is our body's blood proteins. Usually it's 3.5 to 5. It's a good nutritional indicator. It also can help prevent fluid shifts, and we do expect albumin levels to be low with liver cirrhosis because our liver helps process and utilize proteins from our dietary intake. Nutritionally, we're going to look at those fat-soluble vitamins, and I just know it by CADE. So it's vitamin K, vitamin A, vitamin D, vitamin E. We're going to look at their lipid levels. So that's your cholesterol, your HDL, your LDL, your triglycerides, your total cholesterol levels. We're going to look at their vitamin K. That's essential for clotting. Vitamin B12, which is essential for red blood cell synthesis. We're going to look at the ferritin level. Ferritin is a protein that helps our body store their iron. We're going to look at the H&H, hemoglobin and hematocrit. The complete metabolic panel, CMP, that's going to look at all the electrolytes and some kidney function. And then we could look at hemoglobin A1C. That'll tell us their blood glucose control for the past 3 to 6 months. We could do a fasting blood glucose as well. And if that's elevated, we would need to evaluate them further, maybe do a hemoglobin A1C next. Fasting glucose is different than just a glucose. Fasting means they've had nothing to eat or caloric to drink for about 8 hours. A random glucose is just that. They could have eaten, they could have had like a Gatorade or whatever, and it's going to alter that result. Some other nutritional indicators that we may do would be your blood clotting, so your PTINR, PTT, just because our body synthesizes those with help of good nutritional intake. For altered liver function, we're going to look at those liver function tests, LFTs, specifically the ALT, AST. We're going to take a look at the albumin. It's going to be low, typically with liver cirrhosis. Ammonia is a waste product. It's going to be high because the liver might have difficulty getting rid of that ammonia. Bilirubin, again, a waste product. And then vitamin K, our liver helps synthesize that to clot normally. Let's see. Moving on, pancreas, we're going to look at the amylase and lipase levels. Levels that are higher are abnormal, but the higher the number doesn't mean the worse the disease. But these levels can also be elevated if your patient has gallstones and they are blocking the common duct, which could in turn irritate the pancreas. Let's see, kidney, we got creatinine, BUN, GFR, phosphate, and MEG. So creatinine, remember that's a waste product from muscle metabolism. Your BUN is a waste product from protein metabolism. Your GFR is your glomerular filtration rate, so how well are the kidneys filtering? And then your phosphate and MEG are those essential electrolytes that the kidneys help regulate. And then with anemia, we're going to look at a hemoglobin hematocrit, a ferritin for iron, B12 for pernicious anemia, and we could look at an occult stool to see if there's any hidden blood in their stool. Let's see. One thing I did want to touch base on too is with altered liver function, your PT and INR might be elevated. And the reason for that is because the liver helps synthesize our clotting factors. And if we don't have enough clotting factors being made, we're going to have prolonged bleeding times, which is going to make those PT, INR, PTTs higher than normal. And that's a finding that you'll find with liver cirrhosis. And when we talk about liver cirrhosis in greater detail, we will kind of see how that puts them at an increased risk for bleeding, that coupled with some complications that can occur. And then one thing I wanted to mention is P-T-Y-A-L-I-N, Petalin. That is just a fancy word for amylase that's produced in the mouth. You might come across that word, and I just want you to know what that is. So I've just given you a great deal of information on this slide. I highly encourage that you take detailed notes and you go back and listen to this again and let me know if you have any questions. This is all very important information to be familiar with. All right, let me just check my notes. Anything else? We talked ammonia, we talked bilirubin. We didn't talk, and this is just a refresher, the pH of the distal esophagus is 6 to 7, and the pH of the stomach is generally 4 or less. And this is important to know so that you know if you have a tube, whether it's in the correct position or not. And we're always going to use pH paper to test the position of like an NG tube. And then one other lab I wanted you to be familiar with is SED rate, sedimentary rate. That is an indicator for chronic inflammation, which can be helpful if your patient has something like ulcerative colitis. But we're going to talk about that in a future slide too. All right. So that brings us to malnutrition. So this slide shows you all the ways that a body can be affected if a person does not have good nutrition. Malnutrition causes a protein catabolism, which exceeds protein intake and synthesis, which results in a negative nitrogen balance, weight loss, decreased muscle mass, and weakness. And this can be people that have anorexia, bulimia, elderly patients, people that are on really strict diets, like severe calorie restriction. And as you look at all these things and see how in depth, how it can compromise the body as a whole, I want to plant some seeds for you. Hospitalized patients are at risk for malnutrition because they have a significantly increased caloric need. Patients that are NPO, patients that aren't feeling well enough to eat, these people still need to heal. So we need to make sure that we're giving them nutritional supplements in a way to make their caloric needs be met. And sometimes doctors forget about this, and that's when nurses need to step in and say, hey, he's been NPO for a couple of days. Do you think we can discontinue that and maybe, start him on a clear diet, anything like that? Um, this is a moment I want you to think about what you've learned previously about tube feedings and contrast that with what you've learned about TPN, total parenteral nutrition. Remember that tube feedings go in the GI system, TPN goes right into the bloodstream. And remember with TPN, we've got to do some quality assessment of blood glucose because they are at risk when they first started and as they are on it for hyperglycemia. So remember those 3 P's. And when we stop it or decrease it, they're at risk for hypoglycemia. So, and remember the brain is the most sensitive organ to inadequate blood glucose. So alteration in level of consciousness, check your blood glucose. And then just remember this, cold and clammy needs some candy. Hot and dry, they probably are elevated blood glucose. Not a perfect mnemonic, but hopefully it helps. Okay, so I told you we would circle back around to BMI. So there's a table in your textbook that you can take a look at it. It's helpful in general, and it's most helpful with trending. Are they getting better or worse over time rather than just like a single measurement? So it's not a perfect system, but it's a way to get a general idea of their risks. So a BMI less than 19, they're going to have risks for poor nutrition. 25 to 30 is overweight, greater than 30, obese. And we do need to take ethnicity into account, and we also need to take into account lifestyle choices. So if someone is a runner, does like long distance running, their BMI might be on the low side, but looking at doing a nutritional assessment will give us information as to whether we really need to worry about them for poor nutrition. And then BMI on the other side, maybe they're weightlifters, maybe they're a football player for co. So they might be considered obese, but it's just because they have extreme muscle mass. But again, we would still do a nutritional assessment for that. Okay, so clinical exam. What do we need to look at to assess nutritional status? Well, what's their height and their weight? What's their skin, hair, nails look like? Mouth, so the oral mucosa, the teeth, gums, and tongue. Mucous membranes, are they moist and pink? Neck, we're going to look at the structure itself, symmetry, and thyroid. Musculoskeletal, their muscle, how do I want to say this? Muscle definition or wasting. Skeletal is everything in alignment. And then lastly, abdomen. Let's see. We're going to look at their dietary data. So that is going to be usually in a food record. So have them keep track of what they've eaten for a certain amount of time. We could do a 24-hour food recall. Do you remember what you've had to eat in the last 24 hours? We could do a dietary interview. Usually there's a specific form that your facility will want you to fill out. And then are there any religious or cultural considerations that we need to be cognizant of? For example, if per their religion they don't eat a specific type of food. And then those factors that influence nutrition. And I've already talked about these a little bit, but hospitalization know that they are at an increased risk for inadequate caloric intake. Even if they're obese, they still need to have enough calories to heal. Do they have any physical problems or physical limitations? Self-care problems? Um, are they on fixed incomes? Can they not eat healthy food? Do they not have access to that? Are there any cultural influences? Whether, you know, is it not common for them to eat a type of food, or do they tend to eat a lot of a certain food? Those type of things. And then medications. Are they on anything that could influence their nutritional? Like maybe they're on something that makes them feel nauseated all the time, so they're not going to want to eat. So those are just some of the considerations. Um, Dietary and nutrition is usually collaborative, where we will talk with a dietitian and consult with them. And it's very appropriate to link them in and make that suggestion to the physician if we don't have a dietary consult. Okay, so that brings us to the end of the first chapter, and we're going to dive into digestive and gastrointestinal function next. All right, so let's start off with a bit of a review. This should be a refresher from pathophysiology. So the GI mucosa, it's comprised of 4 layers, but it's really very thin. It's only 2 to 5 millimeters thick, and it carries the risk of perforations, whether from a variety of different diseases, surgical procedures, or trauma. I want you guys to remember that the mouth is the beginning of the digestive tract, and the digestion process starts by breaking down carbohydrates, softening and breaking down food. And so we need to think about risk for oral cancer. And with oral cancer, they're going to have an impaired ability to soften and break down their food, which makes it harder to get the nutritional elements out of it. From there, it goes down to the esophagus. It's responsible for delivering food from the mouth to the stomach, and it does that through peristalsis, so that those muscle movements that compel stuff forward, that should be a term you should be familiar with. The trachea also runs right along the esophagus. So again, esophageal issues, we have to think, do we have an open airway? From there, we move down to the stomach. Our stomach is kind of a food holding place, and it mixes it with acid and enzymes to break the food down into a usable form. And then it moves it to the small intestine. And remember, the small intestine has 3 parts: the duodenum, jejunum, and the ileum. And they break down the food, move it through, mix it with digestive secretions, uses enzymes released by the pancreas and the liver to get as much nutritional value as possible out of the food that we eat. The duodenum is primarily the breaking down process. The jejunum and the ileum is primarily absorption of those nutrients. And then remember that contents of the small intestine start out as semi-solid and then end in a liquid form after passing through to the large intestine. So remember, the large intestine, or colon, it's more about water absorption and expelling waste. Remember that, just to back up a moment, I want to touch base on the pancreas and the liver for a second. So the pancreas helps us with digestive enzymes, specifically lipase and amylase, plus trypsin. The pancreas secretes digestive enzymes, which helps to break down proteins, fats, and carbohydrates. Remember that the pancreas also has an endocrine function of producing glucagon, which will raise blood glucose. That's with the alpha cells. The pancreas also produces insulin, which will lower blood glucose with the beta cells. Then we've got the liver. The liver is complex and has multiple functions. It's a digestive function. It processes the nutrients absorbed from the small intestine. Bile is produced to help digest fat. It's our body's chemical factory. It takes raw materials absorbed by the intestines and makes various chemicals in the bodies that the body needs to function, like clotting factors and albumin, which is why we look at those lab values to check for abnormalities. It also helps detoxify from potentially harmful chemicals and uh, body byproducts. It also breaks down and secretes many medications, or I should say, most medications, if you remember that from pharmacology. And then we don't want to leave out the gallbladder. Remember that the gallbladder stores and concentrates the biles and then releases that bile into the duodenum to help absorb and digest fat. So it's really important to have this basic fundamental understanding of each piece of the digestive system. And then we get down to the colon, otherwise known as the large intestine. We've got the cecum, we've got the ascending, the transverse, descending, and sigmoid colon. And then at the tail end, we've got the rectum. So it's primarily to get excess moisture out of our stool, and as it moves its way through to the anus, it gets firmer and firmer. It usually takes about 36 hours for stool to get all the way through the colon. The stool is mostly food debris and bacteria. Now we're finding out that this bacteria is really important because it helps synthesize vitamins, processes waste, protects against harmful bacteria. And then when that colon becomes full, it empties into the rectum. The rectum is kind of a chamber, and the rectum senses that it's full and then sends a message to the anus and the anal sphincter to release the contents. And so that there's a mechanism there of neurological function that has to occur in order for this movement of stool to be coordinated and work properly. It's very important to understand that because people with neurological issues can sometimes have fecal incontinence, and this is why that happens. That's that brain to gut connection that you need to be mindful of. Okay, so let's talk decreased liver function for a second. So decreased liver function can happen due to age or a disease process such as cirrhosis. If there's decreased liver function, there's a higher risk of drug toxicity, which hopefully everybody remembers from pharmacology. The liver is such an important organ, and if it's not functioning properly, you're going to see alterations in albumin, PT, you're going to see elevated bilirubin, elevated ammonia, and ammonia is toxic to the brain, which we're going to talk about a little bit more. So with decreased liver function, and this can also be due to immaturity. So young children don't have fully developed organs. We don't say that's decreased liver function, we just say it's immature, but it can have the same repercussions. But if they have a diseased or aged liver and they have decreased liver function, we expect elevated PT, PTT due to the decrease in clotting factors. We expect low albumin levels due to a decrease in protein synthesis. If there's any sort of damage to the liver, we expect elevated ALT and AST. We expect a higher risk of drug toxicity due to drug metabolism being impaired. And remember that drug metabolism is dependent upon a good blood flow to the liver and liver enzyme activity. Now, the risk is very complicated depending on the medication, but on a basic level, it just allows for more free medication to circulate and to build to toxic levels. And just as a side note, um, I want to plant a seed that low kidney function can also cause low albumin levels just because we're peeing off more protein. But this unit is primarily focused on GI, but I did just want to touch base on that briefly. Okay, so we talked about the liver, which plays an incredibly important role. Let's talk about the digestive tract as a whole. We've already mentioned it. We break down our food, we absorb the nutrients, and then we eliminate whatever isn't helpful. That's our three-step process for our digestive tract. Um, let's talk a little bit about what that means. Digestion is that process of breaking down food into small particles, mixing it with the digestive enzymes, and then absorbing vitamins, minerals through that intestinal wall into the bloodstream, processing it into the liver, and then elimination is the end product. What was not helpful? What did we need to get rid of at the end? And that's what is our stool. Okay, let's talk major enzymes and secretions. So with our chewing and swallowing, we've got saliva, salivary amylase, which is that ptyalin that I told you about. We've got our gastric, so our gastric juices. We've got hydrochloric acid and pepsin are the big ones, and then intrinsic factor. If you remember from pharm, that's what helps our body absorbs the B12 and prevents pernicious anemia. Our small intestine, we have a little bit of amylase, lipase. That amylase and lipase comes from the pancreas and then is shipped to the intestine. So the lipase and amylase have a little asterisk by it for the pancreas because we look at those levels to see if there's any kind of pancreatitis. Small intestine, we've also got trypsin and bile. Remember, bile is liver and gallbladder. Okay, so let's talk assessment. So the purpose of a history and assessment is to find out if there's any current, previous, or family related health problems. This is where we would ask about medications, including laxatives and herbal medications, over the counters like NSAIDs. Do they have any medical issues? Have they traveled recently? That could put them at risk for diarrhea, traveling diarrhea, hepatitis, that type of thing. Nutritional status is when we're going to ask them about their dietary intake. Remember that those NSAIDs and aspirin, so your Advil, naproxen, ibuprofen, aspirin, all three of those can irritate the stomach lining. So be sure to ask them if they've had any stomach pain or indigestion. We want to talk about family history, any cancer, ulcerative colitis, strictures, ulcers, any risk factors for colon cancer like smoking, African American ethnicity. Do they have a history of polyps in their intestines? Do they eat a low fiber, high fat diet? Is there a family history of colon cancer? Psychological comes into play, where we want to assess it for lifestyle and stress. And remember that it's a lot of times difficult for patients to talk about constipation or diarrhea. It's just kind of embarrassing. So you want to kind of build a rapport before you start asking those really hard questions. There are some health history things that are on the slide that you want to make sure you're specifically asking about. Quality pain assessment is critical. And then there are some alert signs and symptoms. These are the signs and symptoms that say, hey, something really bad might be happening. Okay, sorry about that. I had a cough. So those are the signs and symptoms that, something really bad might be happening with our patient that we need to investigate as soon as possible. So the first one, I don't know how to say it, never heard it said. It's basically just blood and urine. The other one is blood in your emesis. Third one is melena, which is a dark, tarry stool. most commonly caused by digested blood. If they have unintended weight loss and fever, all of those things are red flags that we need to do a good assessment and report to the physician. All right, so good assessment means we've got to auscultate all four quadrants of the gastrointestinal cavity, so their abdomen. And this slide I like because it clearly indicates the four quadrants, and it's a reminder of what are we listening to underneath each of those four quadrants. And it's really helpful because depending on where the pain or the discomfort is, it can give us an indication as to what might be the common cause of the problem. And we're going to talk about specific quadrants of pain being linked to specific body organs and disease processes. So one thing I want to talk and remind you of is if there is a bulging in the abdomen, do not palpate the bulge. It could be a serious life-threatening problem such as an abdominal aneurysm, and we want to leave this for the physician to do what they feel is needed. The other thing it could be is a hernia. And we're going to talk about hernias on a future slide. Hernias are a bulging or an outpatching of muscle, and we as nurses do not push them in. And that pushing it in is called reducing them, and we as nurses do not reduce hernias. Physicians do. Okay, so what do? We're going to start with an inspection. What does the abdomen look like? Is it rounded, rotundant? Is it obese? Is it concave? Do you find any lumps, bumps, scars that might indicate a previous surgery? We're going to inspect, auscultate, percuss, and palpate. That is the specific sequence for the abdomen. We always start with the right upper quadrant, go to the left upper quadrant, left lower quadrant, right lower quadrant. And the reason why that sequence is encouraged is because that's the route that the food takes as the digestive system moves it through to expel it out the anus. So we're looking not only for abdominal distension, discoloration, bulging, any tight skin. We're going to auscultate, listening for air and fluid to move through the GI tract. And for normal bowel sounds, you should hear a gurgle every 5 to 15 seconds. If it's every 5 to 15 seconds in each of the four quadrants, you would chart each four quadrant as active. If it's less than every 5 to 15 seconds, you would chart the quadrant as being hypoactive. If it's more than 5 to 15, you would chart it as hyperactive. And so each quadrant must be assigned its own activity level. You can't just chart the whole thing as one, because each one indicates a different step in the process, and each one will give us insight as to how each step is functioning. Now, what if you want to say it's absent? How do you know hypoactive versus absent? Absent, you have to listen for a full 5 minutes in each quadrant to determine if it is fully absent. And if it is absent, that is a medical emergency and you need to notify the healthcare provider. And if it's absent in all four quadrants, double check your work. Check your stethoscope, maybe something else is going on, because all four quadrants aren't going to stop working simultaneously, except for with death. Let's see. Remember, there is a time when they might not have bowel sounds, and that's immediately post-op. So post-operatively, because of the anesthesia puts the body to sleep, that includes the GI tract. It will wake up, and it'll wake up gradually, and it depends on how long were they in the OR, how long were they under anesthesia. What type of surgery did they have? If you are auscultating and you hear hypo bowel sounds or absent bowel sounds in a quadrant, you want to follow up with asking your patient if they've passed any gas in the last 8 hours or a bowel movement in the last 12 hours. If they have, you know that the bowels are working. They're just slow or hypoactive. Okay? So if you get an abnormal finding, your work doesn't stop. Your work just starts. You've got to investigate and figure out what might be contributing to this abnormal finding, and then you need to evaluate, is this expected or unexpected? If it's unexpected, you need to report it to the healthcare provider. So then we said percuss. Percuss, I'm going to be honest with you, we don't do it a whole lot. The purpose of percussion is to listen for sounds. We call a high pitch noise tympanic, and a medium pitch is dull. Tympanics are heard across the abdomen, and dull is heard over the organs because they're solid. Just good to know for an assessment test question on your boards. Palpation is done to determine the size of our organs, but we only do light touch palpation to assess for any gross masses. Only physicians, nurse practitioners, physician's assistants are allowed to do deep palpation. Okay, so we talked about the 4 quadrants, what's inside each of the 4 quadrants. Now, sometimes you can have something called referred pain. So you've got pain someplace other than where the origin is. So keep this in mind when you're doing a pain assessment. And that's why a quality pain assessment is so important. So not just where's your pain and what's the number, but what can you tell me about it? How long has it been there? Does anything make it better, after, worse? What does it feel like? Those sort of things can really help us figure things out. Okay, then I promised we would touch base on hernias. So, a hernia in the abdomen and groin can produce a noticeable lump or bulge that can be pushed back in or reducible, or it can just disappear when the patient is laying down. Crying, laughing, coughing, straining during a bowel movement, or physical activity may make that lump reappear after it's been pushed in. Symptoms of a hernia include a swelling or bulge in the groin or the scrotum, increased pain at the site of the bulge, pain while lifting, increased bulge size over time. They could complain of a dull aching sensation, a sense of being really full, or they could even have signs of a bowel obstruction. So basically what we worry about is that bulge is a weakened muscle, and it's supposed to keep, our abdominal cavity has stuff on the other side of it that's supposed to stay in place. If that wall is weakened, the stuff that's supposed to be in there can push out. For example, part of your intestine can push out, and then it can become trapped, and that can cause a bowel obstruction. It can cause something called strangulation, or a cutoff of the blood supply to that tissue, and that would be in a medical emergency. And that's why we don't reduce hernias. That's the physician's responsibility. There are hiatal hernias. Perhaps you've heard of them, and we're going to talk about that on another slide. Hiatal hernias, there's no bulge on the outside. Instead, they just have symptoms. Symptoms like heartburn, indigestion, swallowing problems, regurgitation, chest pain. And then based on those symptoms, we do further diagnostics to see if they actually have a hiatal hernia. Okay, that brings us to a little bit more assessment stuff. So there's some terminology. These are good things to assess your patient with and make note of if it's a problem for them. What are we going to assess to? We're going to assess for change in bowel habits, constipation, diarrhea. Those can be symptoms of a bigger problem other than are you eating and drinking, eating enough fiber, drinking enough fluids. That's definitely where we start. Diarrhea, we usually think uh, like a bug, like maybe undercooked food, traveling, that kind of thing. But these can also be disease processes too. We have to rule some of that stuff out. So we're going to look at their oral care and dental visits. We're going to talk about that. Any mouth lesions, discomforts with certain food. Do they use any alcohol, tobacco? Do they have dentures? Do those dentures fit properly? So as we look at the oral cavity, and I'm going to tell you right now, we don't usually jump in and do an oral cavity assessment unless they're having a problem. If they tell you that it hurts to swallow, that they feel like they have a lump in their throat, we're going to look in there and see what's going on. And excuse me. And we're looking at the mucosa. Is it pink? Um, is it moist? Are there any white patches, lumps, bumps, ulcerated areas, asymmetry, that sort of thing? We're going to look at the abdominal assessment. If they complain of blood in the stool, they're going to do a rectal inspection to check for hemorrhoids. Then we are going to turn to some diagnostic tests. We could do lab studies, which I've talked about. We could do stool tests, breath tests, an abdominal ultrasound. Abdominal ultrasounds are great because they look at the structure of the abdomen and the organs within there, and it's very safe. There are no known safety risks for having an abdominal ultrasound. Some disease processes have a genetic component. We could do testing for that. We could do some images. We could do a CT, an MRI. Remember, with a CT or an MRI, you should always assume that they're going to have contrast, unless it's ordered otherwise. And remember, with contrast, you have to do some assessment as the nurse. You've got to assess for a shellfish allergy, iodine allergy. We've got to look at renal function because remember, they've got to be able to pee out that contrast. Are they on metformin? Because metformin and contrast do not go together. It can cause renal failure. So usually if they're on metformin, they have to stop it for 2 to 3 days before and after. They're going to get IV contrast. And we're going to tell people to increase their fluid intake unless contraindicated by another disease process, for example, heart failure. And then, because that will help pee out the contrast. And then upper GI tract study, lower GI tract study, we're talking about endoscopy or colonoscopy. Endoscopy, you're going from the esophagus down, usually to the small intestine. Colonoscopy, you're going from the anus up into the large intestine. For endoscopy or colonoscopy, we luckily can go in there, look, and fix problems. But because sometimes that involves cutting, we need to make sure these patients aren't on Coumadin or have had their Coumadin held because then they're at risk for uncontrollable bleeding with those studies. If it's an endoscopy, they're going to be NPO for 4 to 6 hours before. And then we're going to assess that gag reflex before giving them fluid after the study. Okay, we can also do some GI motility studies. How is everything getting pushed through the digestive system? Endoscopic, these are just some specific names. EGD, esophagus, gastric, duodenum. Those are the three organs that they look at with that. Let's see. Barium studies. Barium is a chalky white radio-opaque substance that the client can either drink or be given it as an enema, and it helps to visualize the structure and or swallowing mechanisms. It does carry the risk of constipation, so we have to encourage clients to increase their fluid intake because it will help them poop it out and prevent constipation. And we also need to tell them that their stool might be white until the barium has passed, because that's what barium looks like. It looks real white. Okay, so what are the nurses' role for these GI tests? Well, we got to give them info about the test, why they're done, what it's going to look at, what any prep is. Um, Post-procedural, we're going to give them, okay, what's going to happen afterwards? What kind of activity restrictions? It's good to give them the heads up prior to it, because a lot of times they get sedation or they're worried, have anxiety. So we want to give them a lot of information preventively so that they know what to expect. Before they go in, we're going to make sure they have the education provided by the physician to know why the test was pertinent and that they've given consent. If a patient ever expresses, like, I don't understand or I'm not sure about this, our role as the nurse is to notify the provider that the patient has questions, and then the provider's responsibility is to come and get that informed consent. We can help them cope with any discomfort and anxiety, but we can't get informed consent. It's the physician's role. And then we're going to inform the primary care provider of any abnormal lab values, medical conditions. Like, let's say your patient's got a latex allergy. That should be known right away. What if your patient has a history of renal failure? That should be known right away. What if they've got liver cirrhosis? You got to tell the doctor these things. Maybe they've only met this patient one time before the procedure. Maybe the patient never told the doctor this information. So we want to just have good communication, open communication with the physician, and make sure they know this priority information. We're also going to assess the patient's baseline. We want them to be adequately hydrated before, during, and after, and then provide them education about the benefits of staying hydrated. Because if they're dehydrated, it's just going to cause problems. And it's super easy to prevent just by keeping your focus on that attention. Okay, so I've almost talked for an hour at this point. So I'm going to break this recording into two pieces to give you guys a break and myself a break. I appreciate you listening, and I will pick this back up with the management of oral and esophageal disorders in part 2 of this recording. Thank you so much.